Welcome to the Epidemiology and Prevention of Vaccine Preventable Diseases webinar series. I'm Andrew Kroger. I'm a medical officer in the Immunization Services Division of the National Center for Immunization and Respiratory Diseases, and I'll be the moderator for today's session. To participate in today's program, all you will need is an internet connection. Here are our learning objectives. At the conclusion of the session, participant will be able to describe the different forms of immunity, describe the different types of vaccines. For each vaccine preventable disease, identify those for whom routine immunization is recommended. For each vaccine preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice. Implement disease detection and prevention healthcare services. For example, smoking cessation, weight reduction, diabetes screening, blood pressure screening, immunization services to prevent health problems and maintain health. Today is June 29th, 2016, and on the agenda is the Epidemiology and Prevention of Vaccine Preventable Diseases Pink Book, specifically the chapters on vaccine storage and handling and vaccine administration. These topics will be presented by Ms. Donna Weaver, nurse educator in the Communication and Education Branch, Immunization Services Division in NCIRD. Continuing education, or CE credit, is available only through the CDC ATSDR Training and Continuing Education Online System at www.2a.cdc.gov/TCE online. If you're watching this version live, CE credit for the session will expire on August 1st, 2016. If you are watching the Enduring Archive version, CE credit for the session expires on June 1st, 2018. When obtaining CE, you will be required to provide a verification code. Watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDCR planners and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources for vaccine storage and handling and vaccine administration will be available, and the web page is www.cdc.gov/vaccines/pinkbook/pb4.asp. If you have a question during this presentation and related to this presentation, please type your question into the chat, the Q&A chat pod. I will collect these questions during the presentation, and then we will address them during the question and answer period, which will follow Ms. Weaver's presentation. And so I will now turn the microphone over to Ms. Weaver.
Thank you, Dr. Kroger, and good afternoon, everyone. It's a pleasure to present to you from here in Atlanta. As Dr. Kroger said, our topics today are vaccine storage and handling and administration. If you're following along in the 13th edition of the Pink Book, there have been some updates since the Pink Book was published, so there is some information on these presentation slides that is more current. These slides will be posted within a few days on the webpage for this program. And there is also a list of resources already posted, which Dr. Kroger mentioned. Let's start with vaccine storage and handling, which is Chapter 5, and that starts on page 63 for those that are following along with in the Pink Book. Now here's an image of CDC's 2016 Vaccine Storage and Handling Toolkit, which will be available online later this week. The toolkit reflects best practices for vaccine storage and handling from the Advisory Committee on Immunization Practices, or ACIP, from product information from vaccine manufacturers and scientific studies. The 2016 toolkit has a new design to help healthcare providers find the information they need quickly and easily. The beginning chapters address the main elements of an effective cold chain, which I'll discuss in a few minutes. And then the remaining chapters focus on emergency management of vaccines and developing standard operating procedures for routine and emergency storage and handling. We have also included links to two other resources: manufacturers' package inserts, which include the most current information about storage and handling of specific vaccines. And then some states may have storage and handling requirements specific to their program, so there's also a link to state immunization programs. It's critical that vaccine storage and handling cold chain, which is a temperature-controlled supply chain or environment, is maintained from the time a vaccine is manufactured until it's administered. As you can see in the image on this slide, the majority of the responsibility for maintaining the vaccine cold chain occurs at the provider level. So it's essential to have a well-trained staff, reliable storage and temperature monitoring equipment, and accurate vaccine inventory management. Every facility should have standard operating procedures for daily management of their vaccine supply, and also emergency SOPs that spell out what to do to protect vaccines in the event of an emergency. Now, if you do not have these SOPs in place, there is more detail in CDC's Storage and Handling Toolkit to help you develop them. And be sure to keep them near the vaccine storage units and that your staff is familiar with them. Also, be sure that custodial and security staff knows who to contact if there is an after-hours emergency. There should be one person in your facility who takes primary responsibility for vaccine storage and handling management. And there should also be at least one alternate or backup person who can take over in the absence of the primary coordinator. We also recommend that a physician partner or member of management be directly involved in seeing that these SOPs are carried out. And storage and handling training should be provided to all staff who receive, handle, or administer vaccines during their orientation, during annual updates, and anytime recommendations change or new vaccines are added to your inventory. To avoid overstocking and to ensure that you have on hand the vaccines you need, conduct an inventory of your vaccines and diluents at least every month. Another issue that can sometimes cause problems and expensive loss of vaccines is improperly handling vaccine deliveries. Try to arrange for deliveries when the vaccine coordinator or alternate is available and notify them immediately when the shipment arrives. Examine deliveries as soon as they arrive and then store the vaccines at the proper temperatures right away. Examine the shipping container and its contents for any evidence of damage and cross-check the contents with the packing list to be sure they match. Check heat and cold temperature monitors or indicators if they're included in the shipping container. And you'll need to follow instructions on the monitors for reading and reporting any problems. If a monitor indicates a possible temperature excursion during shipping, the vaccines that are in question should be properly stored separate from other vaccines and marked "Do Not Use." Then, according to your policies, the immunization program distributor or vaccine manufacturer should be consulted for guidance. In addition to well-trained staff, you need the appropriate equipment. CDC recommends using purpose-built units designed to either refrigerate or freeze. A secondary option is a standalone household unit. Now, we know from studies that have been done that these units are the best at maintaining the required temperature ranges for vaccines. Vaccines stored in the freezer should maintain temperatures between minus 50 degrees Celsius and minus 15 degrees Celsius, and that's minus 58 degrees Fahrenheit and plus 5 degrees Fahrenheit. The thermostat should be at the factory set or midpoint temperature setting to assure appropriate frozen storage temperatures. Refrigerated vaccines should be stored at temperatures between 2 degrees Celsius and 8 degrees Celsius. That's 36 degrees Fahrenheit and 46 degrees Fahrenheit. The thermostat should be set at mid-range to achieve a temperature of about 5 degrees Celsius or 40 degrees Fahrenheit, which will decrease the likelihood of temperature excursions. Now, the 2016 toolkit reflects an adjustment in CDC's guidance on the Fahrenheit temperature range for storing refrigerated vaccines. The new recommended Fahrenheit temperature range is between 36 degrees Fahrenheit and 46 degrees Fahrenheit, previously between 35 and 46 degrees Fahrenheit. The Celsius temperature range between 2 and 8 degrees Celsius has not changed and is the same as stated in all manufacturer package inserts for routinely recommended vaccines. Now, it's important to remember that when vaccines are exposed to temperatures outside the recommended ranges, the losses can be very costly, not only in vaccines and replacement, but also in staff resources and confidence in your facility, if patients have to be recalled for revaccination. So it's less costly in the long run to use good equipment that will maintain the appropriate temperatures. If you must use a household grade combination refrigerator freezer unit, only use the refrigerator compartment for storing vaccines. These units have cold spots and temperature fluctuations, and air circulating from the freezer could expose refrigerated vaccines to freezing temperatures. If you are using a household combination refrigerator freezer, leave the freezer on at the factory set or midpoint temperature setting to maintain proper temperatures in the refrigerator. Water bottles should also be placed in the refrigerator to help maintain the correct temperature range and reduce the risk of freezing vaccines. And use a separate standalone freezer to store frozen vaccines. You know, we used to always worry about vaccines getting too warm, but actually more damage can be done if refrigerated vaccines are exposed to freezing temperatures. CDC does not recommend using dormitory-style units at all, not even for temporary storage, and the Vaccines for Children or VFC program does not allow them to be used. Studies have shown that these dormitory-style units cannot reliably and consistently maintain the recommended temperatures for both refrigerated and frozen vaccines. Now you can see that green arrow in the dormitory refrigerator on the right. That little freezer area is not sufficient to maintain the appropriate freezer temperature for frozen vaccines, but it can expose refrigerated vaccines to freezing temperatures. But not all small storage units are dormitory or bar-style units. Compact, purpose-built units are available for biologics and can be used to store vaccines. Just make sure the storage unit has enough space to store the largest inventory that you might have at the busiest point in the year without crowding. For example, during flu season, or maybe when you're doing back-to-school immunizations. For monitoring the temperature in your storage unit, CDC recommends using continuous temperature monitoring devices that have a current valid certificate of calibration testing. This is also sometimes called a report of calibration. This certificate is required for providers who have VFC vaccines or other vaccines purchased with public funds. Calibration testing should be done every 1 to 2 years or according to the manufacturer's recommendation to ensure that the device is continuing to record accurate temperatures. Now this slide and the storage and handling toolkit contain a list of the recommended characteristics for a temperature monitoring device, and many of the state immunization programs can provide guidance on selecting a device. The most important thing is to be sure your staff is trained on how to set up and properly use whatever type of device you have. CDC recommends that you check and record storage unit temperatures each workday, in the morning when you arrive and in the evening before leaving. This should be done even if there is a temperature alarm or a digital data logger temperature monitoring device. Some devices also display the minimum and maximum temperatures. This refers to the minimum temperature and the maximum temperature that your unit reached since you last reset the device. If you have this information available, we recommend that you record these temperatures once daily before resetting the device. A temperature monitoring log sheet should be placed on each storage unit door or nearby, and the following information should be recorded: the temperature, the date, the time, and the initials of the person recording the data. If a reading is missed, then leave that entry blank in the log. The twice daily checks also provide an opportunity to inspect the storage unit, reorganize any misplaced vaccines, and remove any expired vaccines. This information, along with the room temperature, can be very helpful if there's been a temperature excursion and you're seeking guidance on whether the vaccine can still be used. Now, if you have electronic recordings of the temperatures, they should be reviewed at least one time each week. And the temperature data from your recording should be kept for 3 years or according to your state record retention requirements. Always be sure to take immediate action if there's a temperature excursion, which means there's an out-of-range temperature. However, don't immediately discard the vaccines. Store them properly, separate from any vaccines that are not in question, and mark them "Do Not Use." Then, according to your policies, contact the immunization program, the vaccine manufacturers, or both for guidance. Now, there's an image of CDC's temperature excursion checklist on this slide. It's available in CDC's Storage and Handling Toolkit. So if you have an excursion, you can use this checklist to collect and document the information that you'll need when you call for guidance. Now, when preparing to store a particular vaccine, always check the manufacturer's package insert for storage and handling information specific to that product. Avoid storing vaccines near walls, coils, cooling vents, the top shelf, the ceiling, the floor, or back of the unit, because these areas are more likely to have variations in temperature. Keeping vaccines and diluents in the original packaging until ready to use will help maintain the temperature. Avoid unnecessary exposure to light, and it can help prevent administration errors. Stack vaccines and diluents in rows by same type, with rows separated by 2 to 3 inches. This will promote good airflow around the vaccines. Now, you can store vaccines and diluents in their packaging in uncovered storage bins to help keep things organized and separated. Store pediatric and adult formulations on different shelves, and do not store sound-alike or look-alike vaccines next to each other. For example, I wouldn't put DTaP and Tdap next to each other, or Hib and Hep B next to each other. Using labels with vaccine type, age, and gender indications, or that are color-coded, can also help prevent administration errors. We've included links to vaccine labels on our website that you may find helpful. Now, right now, the labels are being updated, but they should be posted within a couple of weeks, once we get all the changes made and we get them through clearance. Do not store vaccines in the doors or deli, vegetable, or fruit crisper drawers, and do not freeze diluents. We've included a link to a helpful job aid about proper storage of various diluents. Also, if you're a VFC provider, consult your state program for guidelines on storing VFC vaccines and privately purchased vaccines. Be proactive and take preventive measures to protect your vaccines. Plug the storage unit directly into the wall. Do not use a multi-outlet power strip. Do not use power outlets with built-in circuit switches or power outlets that can be activated by a wall switch. Plug only one unit into an outlet. Use a plug guard or a safety lock plug so that you don't have to worry about anyone unplugging your unit, like custodial staff. And install a temperature alarm to alert you if a problem occurs when the facility is closed. Label circuit breakers and electrical outlets so that workers who may be in the building will not disrupt power to your storage unit. And post warning signs that include emergency contact information in case something happens when the facility is closed. Use water bottles in the refrigerator and freezer to maintain the temperatures. If other biologics must be stored in the same unit, store them below the vaccines to avoid spillage and contamination of your vaccines. And never store food and beverages in the same unit with vaccines, because this leads to more frequent opening of the unit and can affect the temperature and lead to more light exposure. Inspect your storage units daily to make sure the temperature monitoring device and vaccines are in place and there are no concerns about damage. And most importantly, take immediate corrective action when there's a problem. Now, unfortunately, we hear too often about administration of expired vaccine. Check vaccine and diluent expiration dates a minimum of weekly. Rotate your stock so that vaccines and diluents with the soonest expiration dates are used first so that you can avoid wastage. And get expired vaccines out of your storage units. Some vials have an expiration date that includes the month, day, and year. Others only have the month and year. If month, day, and year are included, then the vaccine can be used until the end of the day noted on the product. If only the month and year are given, the vaccine can be used through the last day of that month. Of course, this only applies as long as the vaccine is stored and handled properly and it's normal in appearance. Now, there are some exceptions to the expiration date printed on the product. Once a vaccine is reconstituted, the clock is ticking. The package insert will indicate the beyond use time or date, which is referred to as the BUD, or some people say the BUD. It may be 30 minutes, 8 hours, 24 hours, or in the case of a multi-dose vial, it could be a number of days. Also, the expiration date may change for a multi-dose vial once it's opened. For example, there are some vaccines that must be used within 28 days once the vial is punctured. And a third exception may occur if there is a temperature excursion. The manufacturer may say that the vaccine can still be used, but they will shorten the expiration date. Now, anytime there's a change in the date, it should be noted along with the initials of the person making the change on the vaccine label. And there's one other precaution that does not relate directly to the date. Package inserts will likely indicate the number of doses that may be taken from a multi-dose vial. Once that number of doses is withdrawn, the vial should be discarded even if there's residual and the expiration date has not been reached. Now, we get a lot of questions about vaccine transport. Vaccine manufacturers do not recommend transport of vaccine unless it is an emergency and the vaccines have to be moved to preserve them. Vaccines that will be used at an off-site or satellite facility should be delivered directly to that facility. Now, if that's not possible, transport of vaccines should only be done using a portable vaccine refrigerator or qualified container and pack out with a calibrated continuous temperature monitoring device. If you must transport vaccines, transport only what is needed for the workday. The total time for transport and workday should be a maximum of 8 hours. If you must transport vaccines in non-commercial vehicles, then use the passenger compartment, not the trunk. Immediately upon arrival at the off-site or satellite facility, vaccines should be stored in an appropriate storage unit with a calibrated temperature monitoring device, and temperatures should be read and recorded a minimum of 2 times during the workday. If vaccines cannot be stored in an on-site storage unit and they must be kept in the portable storage unit during the off-site clinic, the temperature should be read and recorded at least hourly. The container should be kept closed as much as possible. And no more than 1 multi-dose vial or 10 doses should be removed at a time by each person that's administering vaccine. Now, there's more detail on transport in the Storage and Handling Toolkit, and we've developed a job aid for emergency transport that is available on our website. You can see the first page of this job aid and the web address on this slide. Now, that's strictly for emergency transport. Let me make that clear. Now, the vaccine manufacturer does not recommend transporting varicella-containing vaccines. If these vaccines must be transported during an emergency, then refer to the guidelines in the Storage and Handling Toolkit. When you remove the dust cover and expose the rubber diaphragm or stopper on a single-dose vial, you should use that vaccine or discard it at the end of the workday, because you cannot always tell if the diaphragm or stopper has been punctured by someone else once the cover is off. And remember, single-dose vials do not contain a preservative. They are meant for single entry, single use for a single patient. When using manufacturer-filled syringes, the syringe is activated and the sterile seal is broken once the cap is removed from the needle or when a needle is added to the syringe. It should be used that day or discarded at the end of the workday because, like single-dose vials, manufacturer-filled syringes do not contain a preservative and should be used, not stored, once the sterile seal is broken. And when preparing vaccines, do not draw vaccines into a syringe until ready to use it. Pre-drawing increases the risk for administration errors, wasting vaccine, and possible growth of microorganisms in the vaccine. General use syringes are not designed for storage. Consider using manufacturer-filled syringes for large immunization events because they are designed for both storage and administration. And again, more detail is available in the Storage and Handling Toolkit. Now, you should contact your immunization program or vaccine manufacturers for policies about disposition of unopened vials, expired vials, unused doses, and potentially compromised vaccine. But open vials, activated manufacturer-filled syringes, vaccine pre-drawn by a provider, and broken vials and syringes are not returnable and should be appropriately discarded. You should check with your immunization program or state environmental agency about proper disposal of empty vaccine vials. Now with that, let's move on to vaccine administration. So if you're following along in the pink book, this is Chapter 6, which begins on page 79. Not only is it critical that vaccines are stored and handled properly, but they must also be administered correctly to ensure the vaccination is as safe and effective as possible. Vaccinators should follow professional standards for medication administration and the guidance provided by the vaccine manufacturers. CDC also has a website for providers on evidence-based safe injection practices, and the link to this website is included on the slide. Improper administration of vaccines can prevent the vaccines from providing optimal protection and may even lead to adverse reactions and injuries. All personnel, and that includes temporary staff who will administer vaccines, should receive comprehensive, competency-based training on vaccine administration during their orientation, at annual updates, and when there are new recommendations or new vaccines added to your facility's inventory. Knowledge and skills should be assessed before someone is allowed to administer vaccines to patients. Now, if you need an immunization skills checklist, we've included a link to one on the Immunization Action Coalition website that was developed by the California Immunization Program. The patient's immunization history should be reviewed at every healthcare visit. When the patient arrives, providers should obtain a complete immunization history and compare the patient's immunization record to the medical record and immunization information system or registry data if one is available. Use the current immunization schedule based on the age of the patient to determine all recommended vaccines that are needed. Also assess for any vaccines that are indicated based on health status, occupation, or other risk factors. If a documented immunization history is not available, administer the vaccines that are indicated. With the exception of self-report for influenza and pneumococcal polysaccharide vaccine, that's PPSV23, providers should only accept written dated records. All patients should be screened for contraindications and precautions prior to administering any vaccine, even if the patient has previously received that vaccine. And if you do not have screening questionnaires, we've included links to screening forms available on the Immunization Action Coalition website. And use vaccine information statements and other resources to discuss vaccine benefits and risk and disease risk with parents and patients. Aftercare instructions should include information and strategies for dealing with side effects and for determining when medical attention should be sought. We've also included a link to a resource for things parents can do before, during, and after vaccination to comfort their child. When determining patient positioning and restraint, consider the patient's comfort and safety, as well as their age, their activity level, and the site where you're going to administer the vaccine. If you can get the parent involved, this has been shown to increase a child's comfort. Encourage parents to hold their child while the vaccine is being administered, but if the parent is uncomfortable, then of course you can have someone else assist you. Now this slide shows some suggested positioning techniques. Studies have shown that children are less fearful and experience less pain if they're sitting up rather than lying down when vaccines are administered. This seems to reduce anxiety, which in turn reduces their perception of pain. All providers who administer vaccines to older children, adolescents, and adults should be aware of the risk for syncope or fainting after vaccination, which could lead to patient injury. So make sure the person who is being vaccinated is always seated or lying down. Be aware of symptoms that precede fainting, like weakness, dizziness, and if the patient looks pale. And of course, provide supportive care and take appropriate measures to prevent injuries if the patient does faint. Now, the ACIP also recommends that providers consider observing the patient, with the patient seated or lying down, for 15 minutes after vaccination. And that's really more for risk of fainting than it is for an allergic reaction, because if you do good screening, then allergic reactions are really quite rare. Concern and anxiety about injections are common for all ages. Fear of injections and needle stick pain are often the reasons why patients, and that includes healthcare personnel, refuse vaccines. About 25% of adults have a fear of needles, which likely developed when they were a child. Pain is subjective, and it's influenced by many things, including a person's age, their anxiety level, previous healthcare experiences, and their culture. Even though we can't prevent all pain, there are some things that can help. This slide includes several evidence-based strategies to ease pain associated with injections. And we've also included links to 3 videos that demonstrate helpful strategies. Now, our time for this presentation is limited, so we don't have time to show the videos, but I hope you can find time to look at them, because not only are they informative, but they're really entertaining. Now, I'm sure we all know that we need to take every precaution to prevent infection when performing any procedure. So just as a reminder, hand hygiene should be performed before preparing vaccines, between patients, and anytime hands become soiled. Occupational Safety and Health Administration, or OSHA regulations, do not require gloves to be worn when administering vaccines unless the person administering the vaccine is likely to come into contact with potentially infectious body fluids or has open lesions on their hands. If gloves are worn, they should be changed and hands washed between patients. And of course, puncture-proof biohazard containers should be used for discarding injection supplies. Now, as discussed earlier, check with your state immunization program or environmental agency about proper disposal of vaccine vials. Prepare vaccines in a designated clean medication area that is not adjacent to areas where potentially contaminated items are placed. Use a separate 1 milliliter or 3 milliliter sterile syringe and a separate needle for each injection. Needle selection will depend on the route, the patient size, and the injection technique. And always inspect the vaccine and diluent vials for damage or signs of contamination. You should not only check the expiration dates on the vaccine and diluent, but syringes, needles, and even alcohol swabs have expiration dates. Now, we mentioned this earlier, but it's worth repeating. Always use only the diluent supplied by the manufacturer for that specific vaccine. You want to agitate the vial to be sure the vaccine is resuspended and thoroughly mixed and not discolored. You don't want any precipitate or solids that did not dissolve floating around. If it looks suspicious, then don't use it. Now, here are a few nevers when preparing vaccines. Never combine vaccines into a single syringe. Never transfer vaccine from one syringe to another. And never draw partial doses of vaccine from separate vials to obtain a full dose. Now, rotavirus, oral typhoid, and a new oral cholera vaccine are the only U.S. licensed vaccines that are administered by the oral route. For children, oral vaccines should generally be given before administering injections or performing other procedures that might cause discomfort. The rotavirus liquid should be administered slowly down the inside of the cheek, between the cheek and gum, toward the back of the infant's mouth. Now, LAIV4 or FluMist is currently the only vaccine administered by the intranasal route. At the June 22nd meeting, ACIP issued an interim recommendation that LAIV4 should not be used in any setting for the 2016-2017 influenza season. This recommendation was based on effectiveness data from the last 3 influenza seasons in which LAIV4 did not demonstrate statistically significant effectiveness in children 2 through 17 years of age in the U.S. Subcutaneous injections are administered into the fatty tissue found below the dermis and above muscle tissue. The recommended sites are the thigh for infants younger than 12 months of age and the upper outer triceps of the arm for persons 1 year of age and older. If necessary, the upper outer triceps area can be used for infants. A 5/8 inch 23 to 25 gauge needle should be used. To avoid reaching the muscle, the fatty tissue is pinched up and the needle is inserted at a 45-degree angle. Intramuscular injections are administered into muscle tissue below the dermis and subcutaneous tissue. To avoid injection into subcutaneous tissue, the skin is spread taut between the thumb and forefinger, which isolates the muscle. Now, another technique that's used mostly for pediatric and geriatric patients is to grasp the tissue and bunch up the muscle. Then the needle is inserted fully into the muscle at a 90-degree angle. And because there are no large blood vessels in the recommended sites, aspiration before injection of the vaccine is not necessary. Also, some safety engineered syringes don't allow for aspiration. The needle gauge is typically a 22 to 25 gauge needle. The needle should be long enough to reach the muscle and prevent vaccine from seeping into subcutaneous tissue, but not so long that the needle would strike underlying nerves, blood vessels, or bone. And it's important for the healthcare provider to be familiar with the anatomy of the area where the vaccine will be injected. For the majority of infants, the anterolateral aspect of the thigh, or vastus lateralis muscle, is the recommended site because it's a large muscle. For the majority of infants, a 1-inch 22 to 25 gauge needle is sufficient to penetrate the muscle. For a neonate, which is defined as the first 28 days of life, and for preterm infants, a 5/8 inch needle usually is long enough if the skin is stretched flat between the thumb and forefinger and the needle is inserted at a 90-degree angle. Now, for toddlers, the vastus lateralis muscle in the anterolateral thigh is the preferred site. The needle should generally be 1 inch long. The deltoid muscle can be used if there's enough muscle tissue. And a 5/8 inch needle is adequate for the deltoid muscle if the skin is stretched flat between the thumb and forefinger and the needle inserted at a 90-degree angle. The deltoid muscle is preferred for children 3 through 18 years of age. The needle size for deltoid injections can range from 22 to 25 gauge and from 5/8 to 1 inch, depending on technique. A 5/8 or 1 inch needle is required for most young children in this age range. In general, a 1 inch needle is needed for older children and adolescents. But there was one study conducted with obese adolescents that found that a 1.5 inch needle was needed to reach muscle tissue. The vastus lateralis muscle in the anterolateral thigh is an alternative site if the deltoid sites cannot be used, and a 1 inch or 1.25 inch needle will be long enough for most older children and adolescents. For adults, the deltoid muscle is recommended for routine intramuscular vaccinations, but the anterolateral thigh can also be used. Now there's a chart in the Pink Book on page 96 that's based on gender and weight to assist in selecting needle length. Now it's important to use the route of administration that's recommended by the vaccine manufacturer. There are only 2 vaccines that can be administered by either the subcutaneous route or the intramuscular route. They are PPSV23, the pneumococcal polysaccharide vaccine, and IPV, the inactivated polio vaccine. Now, Fluzone Intradermal is the only U.S. licensed vaccine that is administered by the intradermal route. This Fluzone formulation is not the same as intramuscular formulations of inactivated influenza vaccine, or IIV. Other IIV formulations should not be administered by the intradermal route. The site of administration for this intradermal vaccine is the deltoid region of the upper arm. The patient should be seated with the arm bent at the elbow and the hand on the hip to ensure that the site of administration is prominent. The manufacturer pre-filled micro-injection syringe contains a 0.1 milliliter dose. The needle is inserted at a 90-degree angle into the deltoid region of the upper arm without aspirating. Because the needle is very short, as you can see in the bottom right image, the vaccine will be delivered just under the skin into the dermal layer. And do not administer this vaccine into the volar aspect or the inner part of the forearm using the intradermal technique that's used to administer a tuberculin skin test. This one is unique. This one is at a different site and only with this micro-injection syringe. Now this slide shows images of injection site errors that have been reported to us. The image on the left shows a vaccine being administered well above the deltoid muscle. This can cause pain and permanent injury. The image on the right shows a vaccine given too low on the arm for the deltoid muscle, and this could cause pain or even nerve damage. The image in the top middle demonstrates where the deltoid muscle is located and how to use your hand and anatomical landmarks to locate the proper site for injection. You can see that the deltoid muscle is essentially an inverted triangle, and you want to inject into the belly of the muscle, which is the meatiest part of the muscle, where you see that red star. And in the lower image, the muscles of the buttock are not routinely used for vaccine administration. There's the potential for striking the sciatic nerve, especially in infants and children, and the buttock is also not a good site for adolescents and adults because there's typically more fatty tissue there, so the vaccine may not reach the muscle. So just remember, as we say around here, there are no buts in vaccines. If multiple vaccines are administered at a single visit, it's best to administer each vaccine at a different anatomic site if possible. For infants and younger children, if more than 2 vaccines are injected into a single limb, the thigh is the preferred site because it's a larger muscle. For older children and adults, the deltoid muscle can be used for more than 1 intramuscular injection. The injection sites should be separated by 1 to 2 inches. This way, if one of the vaccines causes a local reaction, you have a better chance of knowing which vaccine caused it. Vaccines that are the most reactive, like tetanus toxoid containing and PCV13, should be administered in different limbs if possible. And if you have combination vaccines in stock, then that can reduce the number of injections. If a vaccine and an immune globulin preparation are administered at the same time, then you need to give them in separate limbs. For example, if you have to give a TD or Tdap and also tetanus immune globulin, or say you have to give hepatitis B vaccine and HBIG, just be sure they're in separate limbs. The location of all injection sites should be documented in the patient's medical record. Healthcare providers should consider using a vaccination site map so that all persons administering vaccines routinely use the same anatomic site for each different vaccine. So everyone in your facility would, do them the same way in the same site. And there's a link on the slide to several job aids that were developed by the Michigan Immunization Program that are very helpful when more than one vaccine is being administered. All vaccines administered should be documented in the patient's permanent medical record. Healthcare providers who administer vaccines covered by the National Childhood Vaccine Injury Act are required to document date of administration, vaccine manufacturer, vaccine lot number, name and title of the person who administered the vaccine, and the address of the facility where the permanent record will reside, and the date printed on each vaccine information statement, or VIS, that's given to the patient or parent, as well as the date that it was given to them. Now, best practice documentation also includes documenting the vaccine type, the route, the dosage or volume, and the site. Now, time is limited for today's presentation, but I do want to point out that the vaccine administration chapter in the Pink Book does include strategies to prevent errors. So I hope you'll take a look. And then there's also some other information on the resources page that you may find helpful. So with that, I'm going to turn things back over to Dr. Kroger so we can take some of your questions. And thank you for your attention.
Thank you very much, Donna. I'd like to direct our viewers to the lower right corner of the screen where you will see a pod that contains resources and other continuing education material, including the verification code for today's course. Please make note of this verification code as it will not be given outside of this presentation. Today's verification code is 2016-SH. This verification code applies to both the live program and the enduring program. I'll repeat the verification code, 2016-SH. And I will then provide more details about continuing education at the end of the program. So now I would like to review some of the questions we've received during this program. And you can please continue sending these to the pod. I will remind listeners that if you have a question related to last week's ACIP vote on cholera vaccine or meningococcal vaccine or LAIV vaccine, we are not going to answer these today on this program. Please send them to the NIP info email address that I will give you at the end of this program. And so, Donna, we do have a couple questions that have come in. The first question came in as while you were speaking about the patient care before administration of vaccine, the importance of taking a history and screening. And the question was, should this also include a history of varicella disease, like a diagnosis of varicella?
Well, that if you have a history of disease, that's one of the things that you can accept as evidence of immunity to varicella. So yes.
Great, thank you very much. We have another question that came in about the change in the Fahrenheit temperature, the recommended minimum. The rationale, why is has the acceptable temperature range for refrigerators been changed to 36 to 46 Fahrenheit, and what was the rationale for this change?
Okay, well, this conversion of 2 to 8 degrees Celsius, it actually equates to 35.6 degrees and 46.4 degrees Fahrenheit. And, you know, all of the manufacturers have the 2 to 8 degrees Celsius in their package insert. So most of them say 36 to 46, but there are some that do say 35 to 46. By changing it to 36 to 46, this will align with guidance from the U.S. Pharmacopoeia, or USP, which is a scientific organization that sets federally recognized quality standards for food and drugs. And then by adjusting CDC's guidance for the Fahrenheit temperature, we're ensuring that its recommended Fahrenheit range does not conflict with the package inserts of any of the routinely recommended vaccines. Now, the Celsius temperature has not changed. It's always been 2 to 8.
Great. Thank you, Donna. Question here about inactivated vaccine vials. Do they need to be discarded in red medical waste containers, or can they be discarded in the regular trash?
Well, you know, I mentioned that you needed to check with your state immunization program and see what the requirements are in your state. Sometimes that does vary. So we always defer to the state for that guidance.
Okay, so just defer to the state health department on that. Okay. Question about storage units. Is it recommended to line the bottom of a pharmacy or lab grade refrigerator with water bottles?
You know, I would check with guidance from the manufacturer and with your state program. I mean, typically we say to put the water bottles in there because it serves as a, you know, an extra help to help hold that temperature, especially if you have, you know, a power outage. And then also the reason we don't usually recommend putting vaccines on the floor, on the bottom of the storage unit, is because the further out you get from the central part of the storage unit, the more you can get into temperature variations, or if the motor is down there, then it can be too warm. So you really need to look at your particular unit and where there are variations in temperature, what's the guidance from the manufacturer, and but in general, yes, we do say put the water bottles.
Okay, thank you. A question about administration. Is there any evidence of vaccine efficacy? Is it influenced by the amount of fat in a patient's arm?
Well, when it comes to subcutaneous vaccines, I don't know of anything. I mean, as long as you get it into fatty tissue, I don't know that the amount matters. Now, in terms of an intramuscular injection, then you know, the main reason you try to get it into the muscle is because those vaccines that are given intramuscularly may have an adjuvant in there, and those adjuvants can be irritating to the tissue and cause more local reaction if you don't get it down into the muscle tissue. You don't want it seeping back into subcutaneous tissue. And I think in some cases, Dr. Crow, you may know more about this than I do, but in some cases, I think it could, you know, affect the response to the vaccine.
Yep, yes, for those vaccines for which are, you know, licensed as intramuscular administration, and oftentimes patients administer these vaccines subcutaneously, and we get questions about counting the dose. The concern has been with the effectiveness of the vaccine. Many of the studies, if not all, come from evidence with hepatitis B vaccine and gluteal deep fat muscle, but it is a kind of a natural extrapolation. There's fat in the gluteus, there's fat in the arm, and there's fat that you have to go over to get to administer that dose intramuscularly. You have to go through the subcutaneous fat. So it's partially an extrapolation, but our recommendations remain that for certain vaccines for which we have some evidence where when there's intra-fatty deposition of vaccine, we don't want to count the dose, and hepatitis B vaccine is one. Rabies would be another vaccine for which we have pretty strong evidence of that. So yes, so it's administered by fat. Doesn't necessarily have to be the arm, but if there's any kind of fat, we're concerned about efficacy. We take one more question. Someone's asking about using one needle to draw up vaccine and then changing a second needle to administer the vaccine. I guess the center of this question says that the clinic at which they work insists that they do this. They use two different needles, and we were wondering if you could talk a little bit more about that.
Well, the recommendation from ACIP is that you don't have to change the needle between drawing up and administering unless it's contaminated or there's, something wrong with the needle if it gets bent, or sometimes you'll look at a needle and in manufacturing you'll see there's a little barb on there or something, and then you wouldn't want to use that. But it's not recommended or required, but if it's, if it's something that's part of the policies in your agency, it's not wrong to do it.
Okay, thank you. I think that is all the time that we have for questions right now. So now I will provide some continuing education credit information. Let me thank you, Donna, for answering those questions, and I'll move on to some information. Please go to the webpage www.2a.cdc.gov/TCE online to obtain credit. Today's live CE event course number is WC265-062916. And I will repeat that, WC265-062916. That is today's date and differentiates this presentation from others in the series. CE credit for the live course will expire on August 1st, 2016. You can also search for the Enduring Archive course number, which is different, and that lasts until June 1st, 2018. And that course number is WD2645-062916. I'll repeat that one. That one is WD2645-062916. You will also need the verification code, which is 2016-SH. And this verification code applies to both the live program and the Enduring program. And I'll repeat that verification code again, 2016-SH. For help with the online system, which is available from 8 a.m. to 4 p.m. Eastern Time, please dial 1-800-41-TRAIN. This corresponds to the number 1-800-418-7246. Or for help with the online CE system, you can email ce@cdc.gov. If you have additional questions that you didn't ask on today's program, you may email us at nipinfo@cdc.gov, and we'll try to respond to those as quickly as possible. You can also call in your immunization questions at 1-800-CDC-INFO. That corresponds to 1-800-232-4636. Between 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources that you can use include the Pink Book, and the website for the Pink Book is www.cdc.gov/vaccines/pubs/pinkbook/index.html. It is available online, or you can purchase a hard copy at the link for the Public Health Foundation Learning Resource Center. Our CDC vaccine homepage is cdc.gov/vaccines/default.htm. Our resource guide for healthcare personnel is entitled CDC Immunization Resources for You and Your Patients. It is listed at www.cdc.gov/vaccines/ed/imz-resources.pdf. And you can follow us on Twitter for immunization news, information, and resources for private and public healthcare personnel. That's at CDCIZLearn. I do also want to let you know that we will be also posting answers to the questions that we didn't get to today. And so you can expect to see those questions that you may have written in the chat box or in the Q&A box that we didn't get to. You'll see those posted on our website. And so that will conclude our program for today. I want to thank Ms. Donna Weaver for the presentation today, covering this topic in great detail and for answering the questions. Thank you very much, and have a great day from Atlanta. Goodbye.